The management of CNS infection is really very challenging. They can present as meningitis, encephalitis, brain abscess and nosocomial infections, particularly in the neurosurgical patients. So Dr. Rajiv, how important is to appropriately select antibiotics in patients with CNS infection, and there's a lot of importance you feel is of local epidemiology.
Yes, absolutely. Yes, Dr. Rajesh, I can't really overemphasize this point. CNS, it comes to, it's all confined, it's something is happening inside the cranium. So we don't have
the management of CNS infection is really very challenging. They can present as meningitis, encephalitis, brain abscess and nosocomial infections, particularly in the neurosurgical patients. So Dr. Rajiv, how important is to appropriately select antibiotics in patients with CNS infection, and there's a lot of importance you feel is of local epidemiology.
Yes, absolutely. Yes, Dr. Rajesh, I can't really overemphasize this point. CNS, it comes to, it's all confined, it's something is happening inside the cranium. So we don't have a clue exactly what is happening there. We have to go by different types of tests and so on, and therefore, there is no time to lose, because on one hand you are you're facing a very seriously ill patient, and it's just the brain which is getting damaged, which is such an important part of our body, and it is so irreversible, and therefore one cannot afford to be wrong. Therefore hit right and hit early that dictum is very applicable to CNS infections. If one is facing the community acquired meningitis, we know that it's a matter of few hours when a previously totally healthy person can actually die. And therefore if one can intervene, because these organisms are very rapidly multiplying, they are so inflammatory that they are going to produce rapid destruction of the brain, and within the confines of the cranium there is no space to expand. Raised ICP itself takes a toll and so on. Therefore having the right antibiotic is very important. At the same time, I would also emphasize that there may be a very good role of steroids as well to control the inflammatory reaction, which might happen as a result of destruction of the large number of organisms which occurs with appropriate therapy. So needless to say, the local epidemiology is the most important thing, because you are not going to get enough time for the bacterial cultures to return and positive identification of the organism to be actually done when we start treatment.
I think it is important for you to know the local epidemiology from time to time from your microbiologist and the sensitivity pattern to be appropriate. I think in this there's a lot of importance of giving higher doses, and why do we really give higher doses in CNS infection?
The most important reason is that whichever the drug, the penetration into the CNS is always going to be a difficulty. So the drug needs to be given in the highest tolerable doses. Even in the presence of inflammation, the penetration is less. And another very important point is, as compared to other infections where the dose may be reduced as the patient starts improving, here we never reduce the dose, because the inflammation starts reducing as the patient starts improving, and therefore the penetration may actually go down if one reduces the dose. So the high dose needs to be maintained throughout the duration of treatment.
And see, a lot of time, because there's a lot of talk and there's a lot of rise of the MDR organisms, and the recent studies, they suggest that you should instill through the LP. So what are the particular situations where one should give, in addition to the IV, the drugs through that, and how often they should give it?
Again, this study is, this question is based, the answer is based on not any controlled study, but it is very reasonable that if the drug does not penetrate, even the highest possible doses do not penetrate into the CNS, then one needs some other way to give the drug. So it could be if there is an Ommaya reservoir or an external ventricular drain or a lumbar drain, to very easily instill the drug inside. I already said that there are certain considerations, that the drug should not produce chemical meningitis, the preservative should not produce seizures and so on. So these are some of the limitations. The beta lactams themselves have fairly good penetration, and therefore giving the highest possible doses intravenously is alright for them. On the other hand, the aminoglycosides, the colistin and so on, do not penetrate very well, and therefore one needs to give them intrathecally. Now generally these things are given once in 24 hours, but it will depend, because sometimes a large amount of CSF needs to be let out very soon after the instillation. And although it is said that whatever has been put inside would equilibrate within 1 hour, frequently the patient needs to let out the CSF, in which case the drug will also come out of the CSF, and therefore maybe sometimes twice a day or maybe required in a few instances. But by and large 24 hours is the interval, and the whole thing may be continued for 21 days.
And what are the problems you face in managing these infections regard to repeated LPs, and how often one should do a LP when you have a patient of meningitis, or should you really do it?
In a patient of community acquired meningitis who is improving under treatment, really speaking, there is no reason to repeat the LP also, because it is expected that there is going to be a rapid destruction of the organisms and the person is going to improve. On the other hand, if the diagnosis is uncertain, we need more and more CSF for culturing, then repeated LPs may be required. As a therapeutic procedure to relieve the raised ICP, LP is extraordinarily important in cryptococcal meningitis. In fact, it is really speaking one of the most important therapeutic modalities. In this situation, there is no obstructive hydrocephalus, it's more of a communicating hydrocephalus, and therefore this becomes an important modality of reducing ICP as compared to in TB meningitis. In most other situations, it's not a real method of reducing ICP except in cryptococcal meningitis. So otherwise repeated drainage is not required unless you want to instill the drug inside. We've also had a good experience of actually finding the drug levels in the CSF which are withdrawn while on treatment, and then if we can say that we have reached a good level, it might be a beneficial thing to do. Now again, I need to emphasize that while puncturing the Ommaya reservoir or manipulating or all these connections will have a potential for sending infection inside, and therefore most neurosurgeons are very scared to keep an external ventricular drain or to manipulate it for longer than 7 days, because infection can easily find its way inside. On the other hand, an Ommaya reservoir is somewhat easier to maintain, and the chances of a new infection going inside become quite less if all aseptic precautions are preserved. So needless to say, gloves, gowns, masks, everything need to be emphasized even when the patient is in ICU, when one is going to manipulate the CNS shunts or reservoirs.
So it is important to follow all the infection control practices.
Contact precautions are required.
Lastly, we are now getting the gene expert for the pulmonary tuberculosis, and it has been validated maximum in the sputum positive patients. So in CNS infections, do you think this gene expert has any role in the current settings?
It definitely has a role, because it is something which can give you the information very, very quickly. But if you look at the performance of the test, it is not quite as good as for sputum. And perhaps the reason is the microbial load in the CNS is not that much. We don't see so commonly CSF which is smear positive. On the other hand, it is very common to see a sputum smear positive. In other words, the microbial load is less, and therefore even with this sophisticated test, the sensitivity of picking it up becomes less. There is no study which says that 3 samples of CSF might improve the sensitivity, but I think it might happen, but comparatively the sensitivity is not that much. In our center, for example, it could be roughly only about 30%. However, the published figures are as high as 60 to 70%. Again, the quantity of CSF which is submitted for this test also makes a lot of difference. Often we do find that patients who are not responding to treatment, either because they are developing resistance or something like that, these tests become positive.
Thank you, Dr. Rajiv. So this in management of CNS infection, one has to be appropriate, one should rely on local epidemiology and do the lumbar puncture as and when it is indicated. Thank you.
Thank you.